All right, good morning, everybody. It's a pleasure to be here, getting an opportunity to present some of the research I worked on, and I just want to thank all the faculty and our awesome research staff for helping with this project. This was a prospective cohort that we looked at during my time here, and title of the talk's Opioid Use After Discharge Following Primary Total Joint Arthroplasty, Are We Over-Prescribing? So my talk, just an overview. I'm going to go through a little bit of background and the scope of the hypothesis and then kind of follow the format of a typical paper, and we split the results into the total hip and total knee cohorts. So every day in the US, there's 90 deaths from opioid overdose. And in 2015 alone, there was 15,000 from prescription opioids. CDC is estimating that this is a drag on our economy of about $78.5 billion a year. Obviously, it's all over the news these days. In 2017, the Trump administration declared the opioid epidemic a public health emergency. And even in our most recent AOS Advocacy Now, there's updates on the latest legislation going on surrounding opioids. In 2 weeks in June 11th and 18th have been declared Opioid Week for opioid education and where we should be going with this and how we can play a role in helping reduce the epidemic. And it's really an interesting cultural problem. If you look around the world, we're only 4% of the world's population, yet we consume 80% of the global opioid supply and 99% of the hydrocodone supply. And then where do we fit in as orthopedic surgeons? From a paper I was looking at, we are in the top 5 opioid prescribers per specialty in almost every age group. And this is including general practitioners and family medicine docs. The other thing I learned from this is dentists prescribe a lot of pain meds. But what do we know about opioids and total joint arthroplasty? Well, there's a lot of big database studies out there. And they've given conclusions on risk factors for prolonged opioid use, such as younger age, pre-op use, female gender, poor health status. And they've also shown that prolonged postoperative use and preoperative use are predictors for increased risks of short and long-term complications with primary total joint arthroplasty. So we know we need to address this and do better, but our question was really, what is too much? You know, I remember as a resident starting to discharge patients from the floor, and it was just my senior resident saying, yeah, you know, send them out with 120 of Oxy-10s or whatever. You know, it's like, you just don't want them calling. That is how I initially was being taught on how to prescribe these. And if you ask around, a lot of folks, you know, don't really have good evidence-based data on what they prescribe. And you'll see here, there's a lot of variation in what providers do prescribe because we did not standardize what was being prescribed prior to initiation of this study. So we wanted to quantify postoperative opioid use after discharge from primary total hip and primary total knee arthroplasty. We hypothesized that the total morphine milligram equivalents prescribed would significantly exceed those consumed, resulting in excess number of pills sitting around in people's cabinets available for abuse or diversion. There were 65 primary total hip patients in the study, 50 primary total knee who completed these pain journals detailing their VAS pain scores post-op, as well as their opioid consumption. So this is the demographics for the hip cohort. There's about an equal spread of men and women. Average BMI is slightly overweight at 26.7. Majority of our patients are getting a spinal and general anesthetic. This may not be applicable to all total hips. So say right here, you know, 95% of this cohort is a direct anterior hip. And then our length of stays, you know, with where the trend is heading is, you know, 0 to 1 midnights for the vast majority of our patients. So this is a breakdown of the opioids that were prescribed. So you can see here that there was 7 different types of narcotics prescribed for post-op pain. So I think this is an area where we could improve on, and you know, you see a basically even split between those who are prescribing a pill that includes the Tylenol, such as a Norco or Percocet, and decoupling the Tylenol from the opioids, such as oxycodone or tramadol. This is the weekly average VAS pain scores for the total hip cohort. On average, patient's pain is about a 2 or a 3, and you see a max. There's some patient reporting up in the 8s and 7s, or you know, the problem patient that's calling in, and there's some patients saying, hey, I had no pain at all. Percent of patients, so this one was interesting. And this is the percentage of the patients in the cohort that were taking opioid medications broken down by post-op week. So certainly the majority are needing medications in the first week, but you can already see by post-op week 2, half of the patients were no longer taking opioid pain medications. And by the end of post-op week 2, oh, sorry, I had something that was supposed to appear there, but in any case, 87% of patients are, or over 80% of patients are off of opioids by the end of post-op week 2. And we had something like 12 patients, which was over 10%, which required no opioid pain medications at all. So total morphine milligram equivalents used. So you can see here, 87% are falling below 300 morphine milligram equivalents. And sorry, that was the 12.3%, which took none at all. But what's a morphine milligram equivalent, right? Let's talk about this in terms of something that makes sense to everybody. So hydrocodone or a Norco 5 is 5 morphine milligram equivalents. It's pretty much a 1-to-1 ratio. The oxycodones and Percocets, that's a 1 to 1.5. And the tramadol, it's a 1 to 0.1 morphine milligram equivalent, but most of the tramadol that gets prescribed is a 50 milligram tab. So that's still a 5 morphine milligram equivalent per tab, the same as a Norco 5. So I just point that out because a lot of folks feel better about themselves putting patients on tramadol, or, you know, oh, tramadol is not a real opioid, but it is a synthetic opioid. It's an opioid. And it's equal in morphine milligram equivalents to a Norco 5. So results here, our average morphine milligram equivalents prescribed was 512.6, and the average used was only 159.1, leaving over 300 morphine milligram equivalents unused. So that's, you know, on the order of, you know, 60 tabs of Norco 5 for every hip patient sitting unused in their medicine cabinet. And that was statistically significant looking at that with a two-tailed student t-test. So then we cross-referenced these patients against our statewide narcotic database, which was great. We have this cures database here, so we could see if patients were getting prescriptions that we didn't prescribe, or if they were telling the truth on these pain journals, because that's what we were relying on, that they're going to fill it out diligently and they're going to account for all their opioids used. So we did a pretty good job, actually, at getting some patients off narcotics. A quarter of the patients were taking opioids before even having surgery. And at the 3-month post-op mark, their cross-reference on the statewide database, only 2 patients were still getting refills. Now, all of our patients reported on the pain journals that they were off opioids by the 6-week mark. But you can see that that really wasn't the case here. We had a couple that were still using it, getting refills at 6 weeks, a couple at 3 months, and one that was going to an outside provider for opioids. Our 2 that were using at 3 months, one was a chronic pain patient, and one had gotten a prescription filled from, that refill was actually for a staged procedure. It was being prescribed preoperatively, and they were going to get their second total joint done. So we'll move on to the total knee data. Total knees, different animals, so we keep this separate. Again, about even split male and female. BMI, these ones were a little closer to median obese on average, 29.1. I have this on cue. We are sending patients home with a indwelling adductor canal catheter that gets infused until post-op day 4, and they have them removed for the vast majority of patients. And on average, length of stay is about 1.6 days. Again, a lot of disparity between different narcotics being prescribed, but in general, people are prescribing stronger opioid medications for the knees and more of them. The VAS pain scores also are coming out a little bit higher for the knees, not unexpectedly, you know, more in the 4s and 3s earlier, and it takes a longer to tail off, and you see there at week 6, the pain level bumping back up again, perhaps as they're getting more aggressive with, you know, finishing off their range of motion or strengthening. Every single patient was taking pain medications in the first week post-op, and then it slowly tails off. But unlike with the hips, where very few patients required refills, in this cohort of patients, the total knees, 46% of patients are requiring refills. Now, this causes an interesting problem because I'll get to that in 1 second. And then they're taking more of them. So 0 to 500 morphine milligram equivalents was about 26 patients. And then it's starting to tail off, but we're looking more in the thousands, whereas in the hips, that wasn't the case. So here is, if we just look at morphine milligram equivalents prescribed versus used. Now, this is the initial prescription. So I said that a lot of patients needed refills. So that's a good thing, right? We're not giving their initial prescription so high that, you know, a lot of patients are running out. That's why the used is higher than the initial prescribed. But if you look at, when you account for the refills, then the average morphine milligram equivalents prescribed, including all the refills, now jumps up to 1,370, and now you're ending up with that same problem of a lot of unused opioids. So, you know, if we're trying to fix the problem by just driving down the number of tabs prescribed so low that every patient's having to call for a refill, well, then you're running into a danger of over-prescribing with each subsequent refill if they don't use that one. So it's a little bit difficult to address with just trying to strictly drive down the number so low, you'll eventually be over-prescribing with the refill medications. So in this cohort, there were a third of the patients were on narcotics pre-op. At the 3-month post-op, only 8% were still filling prescriptions, and 10% of the patients were filling prescriptions with other providers post-operatively. So in conclusion, we're caught in this dilemma. We don't want our patients and their loved ones at home in agonizing and pain, you know, calling us incessantly about needing more pain medications or feeling like they're having a poor quality of care. And then the pressure also on the other side of having 0 pain medications left over for this problem of abuse and diversion. And so, you know, where do we go from here? Well, I think in general from our data, it's pretty safe to recommend that you probably shouldn't be prescribing more than 300 morphine milligram equivalents for a primary total hip in an opioid naive patient. That equates to about 60 tabs of Norco 5 or the Tramadol 50s or 40 of the Oxy 5s. And in the total knee cohort, the 500 to 600 morphine milligram equivalent isn't a reasonable initial postoperative prescription, but you're going to expect that some of these patients are going to be calling back for refills. We'd recommend that the easy knee-jerk reaction is when a patient calls for a refill is just to hit that refill button and they get the exact same quantity as they did before, but I would encourage providers to taper the quantity prescribed as they get their refill medications. And then the final key, where I think the real final thing and all this is going to go, is patient education regarding disposal of unused narcotics. You wouldn't believe how difficult it is to get rid of these things. If you Google, you know, what do I do with my unused opioids? The FDA website says, you know, mix it with cat litter or dirt, put it in a Ziploc bag, or throw it away. Or if you look for a center that's willing to take them back, I only found one in our area. There was a Walgreens in Tustin that's willing to take back these medications, but they can't even go back to, most of these patients can't go back to their same pharmacy and drop them off. And they paid for them, so they don't really have any incentive to do that anyways. They figure it's useful to keep around if they're in pain for some other reason later. So I really think that if our goal is to get all these unused narcotics out of the community, there needs to be, you know, pharmacies that are dispensing these need to be required to take them back, and there needs to be some sort of incentive for the patients to return the unused pills. Because we can do better at targeting the quantity prescribed, but you're never going to be able to predict it exactly. So some weaknesses of the study: we relied on patients filling out their pain journal accurately. Right now it's relatively small numbers, but enrollment is ongoing. Some strengths: this is prospective data and the first granular data that I'm aware of on prospective US VAS pain scores and opioid use post-discharge from primary total joint. Some future directions: as we get larger numbers, you could do more powerful statistical analyses and maybe get a better idea of which patients are going to be those that need very few or no opioids versus the people who are going to be high utilizers. Thank you.